Ka tangi te titi, ka tangi te kaka, ka tangi hoki a hao ti he mauri ora. E na mana, e na reo, aura raka te rama, a tēnā koutou, tēnā rā koutou katoa. Ko waiao, ko no otopoti a hao, ko kotarani te iwi, he kai mahi a hao te whare wananga o tākou, ko Richard Blakey tāka wingawa, tēnā koutou katoa. Kia ora everyone, and welcome to this wonderful event celebrating the inaugural Professorial lecture of Professor Jonathan Broadbent. My name is Richard Blakey. I'm the Deputy Vice-Chancellor for Research and Enterprise, representing the Vice-Chancellor here tonight. The Vice-Chancellor is passes on his apologies for not being able to attend, but is an aficionado of looking at many of our IPLs online subsequently. He's off on a trip to the Pacific right now. These are celebrations of achievements and the academic life of the university, in which we invite colleagues, members of the professor's family, members of the Dunedin community, and actually through our live web stream, members of the global community. So to you all here and to the Four Winds, no mai, haramai, tauti mai, welcome. The order of proceedings for tonight is I will try and say as little as possible, but then we will hand over to Paul Cooper, the Dean of the Faculty of Dentistry, to introduce Jonathan's speech. I will then have some votes of thanks and have opportunity for fellowship at the staff club at the end of the evening. I just want to set the scenes by indicating why we take these occasions seriously and why we love to celebrate the promotion to professor. Particularly for someone like myself, actually, Jonathan, that actually came through through our undergraduate programs. Firstly, it's an affirmation of what we do, that our programs are good and sound, and that we graduate people who have the capability to go on and achieve at the highest level in their academic or their professional or their community lives. And promotion to professor is the highest achievement in one's academic life, and so we like to celebrate that. We like to hear from the professor about the things that contributed to their development and to where they are today, because it requires special excellence across all of the three components of an academic role of teaching, research and service, measured by international standards. We get international referees to judge our professorial appointments, in addition requiring significant academic leadership, and Jonathan has shown all of those characteristics. And so it is right and appropriate that we're here to celebrate, and I will also acknowledge that you have some special guests attending tonight as well, through your parents Roland and Carolyn. Tēnā kaurua to you both, to your wife Isabella, who I believe can come now that there's a babysitter at home, to Lawrence and Harold, welcome, and I hope you have fun tonight. And I believe that there's a couple of kids, Casper and Monty, at home, no doubt glued to the screen watching Dad give his professorial lecture in his funny gowns and robes. So to you and to all of your other special guests who are here or online, a special welcome. I don't want to steal any of Paul's thunder, but I do want to acknowledge that your academic and professional service has been exemplary, Jonathan, that the ability to influence policy, practice, teaching and learning in your academic field in areas that affect all of our daily lives are things that we are going to hear about tonight. So we're immensely proud of the work that you've done for us, Jonathan, and I'm looking forward immensely to hearing about that work tonight. So on behalf of the university, please accept our congratulations for your appointment, and I'd now like to welcome Professor Paul Cooper, the Dean of the Faculty of Dentistry, to introduce you more formally. No mai haramai, tēnā koutou katoa. Thank you.
Thank you very much. Tēnā koutou katoa and good evening. It really is my pleasure to introduce today's speaker, Jonathan Broadbent. I just want to say a few words about his stellar CV, as has already been alluded to. Jonathan completed his primary dental qualification at Otago in 2003 and is a dental public health specialist. He completed his PhD in 2010 on caries, trajectories, disparities, and he has also obtained a postgraduate diploma in community dentistry in 2012. Previously, he has been a research fellow and senior research fellow working on the Dunedin Multidisciplinary Health and Developmental Study, better known to us all as the Dunedin Study, which is world-renowned. He has worked on this in positions supported by the US National Institutes of Health and the Health Research Council of New Zealand. In 2012, Jonathan was appointed to senior lecturer in the Department of Oral Rehabilitation, and in 2017 he became associate professor prior to him recently becoming full professor. He has also previously worked in private dental practice, and he has provided dental aid in the Pacific Islands. He was a volunteer and registered essential worker during the 2020 COVID-19 lockdown, providing emergency dental care to the Dunedin public. Jonathan conducts his research as a principal investigator with the Dunedin Study and has led international research in applying trajectory modelling techniques in dental longitudinal studies. He has been awarded several research grants as principal investigator, totaling 1.4 million and 8.2 million as co-investigator. He has published over 100 manuscripts in the scientific literature. He has numerous collaborations throughout the world with 156 co-authors listed on Scopus, and he is a sought-after manuscript and grant reviewer. He has numerous examples of media engagement and has provided expert advice to several government agencies. Throughout his career, Jonathan has been awarded many prizes, including being a recipient of the New Zealand Dental Association's Award for Research in 2001, the Outstanding Young Dentist Award in 2011, the International Association for Dental Research ANZ Division Investigator Award in Preventive and Community Dentistry in 2015. He was a joint recipient of the New Zealand Prime Minister's Science Prize in 2016, and in 2017 he received the NZ Health Research Council's Lillet Medal. Jonathan is the current president of the New Zealand section of the International Association for Dental Research, and he is a past president of the Otago branch of the New Zealand Dental Association. He has also been a member of the IADR Young Investigator Award Committee. He has several scientific journal editorial roles, including being the New Zealand Dental Journal Scientific Editor, the Journal of the Royal Society of New Zealand Associate Editor, and for BMC Oral Health, he is an Associate Editor. Jonathan has supervised 5 PhDs, 3 Masters in Community Dentistry, and 6 Doctor in Clinical Dentistry students, as well as many undergraduate student projects. Jonathan has had many teaching and teaching coordinator roles in dental public health and epidemiology areas in both the undergraduate and postgraduate dental curricula. He has taught clinically at all levels of the BDS program, and he has previously been BDS Year 2 Chair. I know Jonathan is passionate about using his research finding to develop processes for a better and fairer oral health in Aotearoa, New Zealand. So I'm very much looking forward to hearing Jonathan's presentation. So if you could please join with me in welcoming Jonathan to the lectern, please.
Thank you very much, Professor Cooper and Professor Blakey for that kind introduction. And thank you to my friends, the guests here. I really appreciate your attendance to come to listen to what I've got to say this evening. So in thinking about what I wanted to talk about, how I wanted to title this talk, I thought of the spine title of my PhD thesis, which I had called Caries, Trajectories, Disparities. The 3 main things, I think, summarized what my PhD thesis was about. But this is all built on one particular study, the Dunedin Multidisciplinary Health and Development Study, So in planning my talk, I thought that I would do something that looks a little bit like this. So this is my timeline for my talk, my outline. And this is constructed according to 0 to 5. The first dental assessment in the Dunedin study was at age 5 years. That was my early years of life. 5 to 9, the next dental assessment was at age 9. That's where I learned my 3 R's. Then 9 to 15, where I developed some curiosity, found my direction towards dentistry between 15 and 18, which was the 4th dental assessment in the Dunedin study. My dental training began at age of 18, and it continues to this day. I am still being dentally trained, but our next dental assessment was at the age of 26. And then my early research, and this is where I had the opportunity to become involved in the Dunedin study for the age 32 assessments. And that was where I began, really, my research career began in earnest. And then when I became established in my career between the ages of 32 and 38, and now we're thinking about where we're headed now and in the future. So I'm now just hit the early 40s, 41. So that's my rough outline for my talk today. So I begin with my early years. And so this is my family, my father, Roland, my mother, Carolyn, and my 2 older siblings in the first image there, Christopher and Julie, and I'm the baby in the image. I was born in Australia. My dad is a pediatrician, and we're New Zealanders, but part of his pediatric training was in Australia. There I am in a cardboard box, sitting out in the Australian sun. And within a few short months, we had moved to Canada, and they had an extremely cold winter, and there I am dressed up for that. And then you can see here, this is when our family was complete with my younger brother, James, in the picture there also. In New Zealand, ko Taranaki te maunga I ru nei taku nako. Taranaki is the mountain I think of when it's the mountain that brings me peace, if you will. And this is myself and my younger brother James standing in front of Mount Taranaki. I'll come back to this at the very end of my talk. But we originally lived in New Plymouth. Here is me pointing out some lost teeth, my 2 lower central incisors lost to some pieces of Lego. And I am wearing my bike chain around my neck as would be expected. So no Autipoti aho, we moved to Dunedin. And this is a postcard my grandfather wrote me. Dear Jonathan, I had to go to the dentist yesterday, get a tooth pulled out, and it didn't hurt at all. I had 2 others filled, and we'd love to see you. Nana says she'd love to see you, but we don't know when that will be. Now this is me as a young boy there. Between moving from down to Dunedin, my hair changed colour, and things were never quite the same again. No, but I started homeschooling at this stage. So we started homeschooling actually before moving to Dunedin. I'd been to school for about 10 weeks, and there were some incidents that led to us homeschooling, and we homeschooled right throughout these years. My parents had the idea that they'd like to teach us at home, and so they did. We had a lot of opportunities in homeschooling. This is between the ages of 9 and 15, if you will. I I grew my curiosity and my creativity in that time. I learned to play music. I began playing the cello. Judy Davis, my cello teacher, is here down the front. I got some of my old notes from homeschooling as well. I saw some stuff I'd written. You can see my handwriting has devolved since then. I include a picture of the World Book Encyclopedia because during my homeschooling years I read it from end to end, except we were missing the volumes CA to CH, so I don't know anything about Canada to China. I also had a bit of a passion for, I enjoyed things science. So that image there's actually one of my rockets is pretty high up in the sky there. We might be able to see it on the image just about up here somewhere. And this here is I was really into hobbies and making things, and this is a chess set that I made. I really enjoyed playing games like that. So that was sort of that period of my life, if you will. But then finding a direction towards dentistry. During my early years, I had been fascinated by insects. I wanted to be an entomologist. I told everybody this. I was interested in the study of insects. I wanted to do zoology. Until one day my mother said to me, "Have you ever thought about doing dentistry?" And I thought to myself, that's exactly the sort of career that I would like to enter. So I immediately started thinking about this, and the next time I went to the dentist, to Peter Ashton's dental surgery in Dunedin, I asked him about this. Unfortunately, I needed to have a filling at the time, and this is my tooth here, my poor tooth 1-6, which is restored to this day. But he wrote in my notes that he would offer me a job if I got into dental school, and I also asked for a tour of the dental school. And so at that time, the age of 16, I toured the dental school. I met Professor Jim Hood and got to smash some things on his universal testing machine. I met Professor Nick Chandler and got to see his laser Doppler pulp tester. And I met some undergraduate dental students and had the opportunity to drill some plastic teeth. Now, I studied very hard during that period because I was concerned about not getting into dental school. So I studied extremely hard and was very focused during that period of my life. By hook or by crook, I got into dental school and I learned a few things along the way. One of the first things I learned at dental school was the value of teacher feedback. So one of my early assignments was marked by a certain academic, Professor Tom Karos. And he gave me some feedback which he wrote all over my paper. And I took that feedback to heart, and he kept writing repeatedly, "Where's the evidence? Where is the evidence?" He wrote repeatedly throughout my paper. I hadn't cited enough literature. And so I learned from that. And so the next assignment I submitted, that wasn't a problem anymore. I really enjoyed the writing side of this. I enjoyed writing my assignments. I got a bit of a curiosity for the science of dentistry. One of my assignments I have as an example, this is from my second year. I'm sorry, Mum, but it reads, the title of the assignment was Cross-Infection Control, Theory and Practical Implementation of Cross-Infection Control in Dental Practice, The Simple Barriers. Last month, my mother attended a dental appointment at my family's dental practice here in Dunedin, but the dentist was away and a locum was taking care of his patients. The gentleman was unwell and sneezed heavily during the appointment, yet did not wear a mask. He found it necessary to use his pocket handkerchief twice during the appointment, blowing his nose without removing, replacing or washing his gloves, yet going straight back to the mouth with the soiled gloves. Remarkably, my mother did not complain at the appointment, but told me all about it afterwards. So I built the assignment on that, and I enjoyed writing. But then taking opportunities for research. And so my father said to me one day, he'd asked me what the frequency of medical emergencies was in dental practice. He'd been thinking about this in pediatrics. And I asked Professor Tom Cardos, who was taking my laboratory, and he took me straight down the hallway and introduced me to this gentleman, Professor Murray Thompson. And I found in my filing cabinet the other day the first piece of feedback that Murray ever gave me, which he scribbled over, surprisingly little there actually, considering how much he usually writes. But upon asking this question, we set off on my first research project. I was a BDS2 student, and so far as I'm concerned, I sort of feel like I started my research career with a bit of a hole-in-one, to use a golfing term, because from this paper I was awarded the NZDA Award for Research, in no small part thanks to the guidance, completely thanks to the guidance of Professor Murray Thompson. And this created some more opportunities. So later on, as an undergraduate student, a couple of years later, I then conducted a case control study with Professor Murray Thompson and Katie Ayres in paediatric dentist in the field of looking at ADHD as a risk factor, attention deficit hyperactivity disorder as a risk factor for dental caries. Now, at this point, after graduating from dental school, I was at a bit of an impasse, and I was all prepared to go to a hospital job in Auckland, until I thought about it very carefully. I effectively decided that I was going to go to Auckland, but Murray Thompson had suggested that maybe I could stay here and work with him as to help conduct the dental examinations for the Decayed study. And I'd all but made up my mind. I got up the morning of deciding and looked at the horoscope for Sagittarius, and it said, "You're going to make a bad career decision today. Don't make any career decisions." So I decided that I was going to stay and I was going to work. I do not believe in horoscopes, so I did the opposite. So my PhD pathway, it was wonderful to get the opportunity to work with the Dunedin Multidisciplinary Health and Development Study. The study members are now in their early 50s. And when I became involved in the study, they were just commencing the age 32 dental examinations. The leader of the study, Professor Richie Polton, and a very multi-talented a team of people working on that study. Fantastic to work with them. Now, a fantastic opportunity because of the nature of the Decayed study, its scope, but also because it is world-leading in the fact that it includes extremely good quality dental data due to the foresight of a dental academic who had incorporated, Professor Harvey Brown had incorporated dental assessments in the Decayed study from an early stage. So today this is what we're doing, what we did at the age 45 assessments, for example, with self-administered questionnaires and a comprehensive dental examination with a short interview with the dentist. We're examining the temper and the jaw joint, examining people for oral hygiene, examining them for the state of their teeth, their gum health, taking samples of their plaque, and also scanning the teeth in 3D. There's an image of how that works here. We sort of get dental takeaways, if you will, so that we can then do further work with these images later. Now, in the early days of my involvement with the Dunedin study, there was a little bit of travel involved. There was a gentleman, Mr. Sean Hogan, that I had the pleasure of travelling with. This is him fishing on the pier. We had to travel to see Dunedin study members after seeing the main bulk of the Dunedin study members here in Dunedin. There were some that we had to travel to see. And this was a really great way for me to wet my teeth in research, if you will. But it was what was really important was the people who led me through that. And so Professor Murray Thompson was there right throughout that, together with Professor Richie Poulton. Here's an image of myself. This is Murray Thompson at one of our early dental conferences in Ireland. The other image is more recent. There's an image of Professor Richie Poulton and myself at 2005, Dunedin Study event, and more recently when the study was awarded the Prime Minister Science Prize. And you'll also see there one of my other PhD supervisors, the late Professor Jules Keyser, who guided me as well through that time. Now, in my early time of research with the Dunedin study, one of the first things I did was look at the data that we already had, the age 26 data. And what I was interested in doing was looking at, I was interested in looking at rates of tooth decay through life, and so I felt that I needed to know how I was going to be measuring how much tooth decay the Dunedin study members had experienced. So as one of my assignments I began to work on this and looked at different definitions, different ways of making the rules for diagnosis of or classification of how much tooth decay someone had experienced. So DMF refers to decayed, missing and filled, tooth surfaces or count of teeth. And then there's different ways to adjust for how much tooth decay has occurred between two time points. Adjusted caries increment, we use the term increment to describe new decay, or whatever the method might be. Now that's quite important because how you measure that determines how wide or narrow the inequalities you might observe by socioeconomic status. And you want to be able to reasonably, more accurately describe how much tooth decay someone had actually experienced. And so that absolute difference in tooth decay experience could be effectively almost doubled according to how you were calculating that at the age 26 assessment. So I got on to that, into trajectories. This is me in rocket. I'm still into rockets. I try to keep up with what's happening in rocket science around the world. Now, this was something I did from that calculation, calculating the count of decayed tooth surfaces by age in the Dunedin study, just looking at the permanent teeth, the adult teeth. And taken as an average, using this adjusted measure to account for how much tooth decay the study members were likely to have. It gets confusing when a person loses a tooth, because a person who loses a tooth loses the whole tooth, but often it's just a small part of the tooth that is actually decayed, particularly for a low-income person. A person who is low-income will have a tooth with a small amount of decay extracted very early, whereas that would be more severe for a more well-off person. And so this was the beginnings of that trajectory analysis work. This was an early version of it before adjusting to a more developed version. And so this image here, you can see the how a certain proportion of the population, about 40% of the study members, had a low trajectory of dental caries experience. About 45% had a relatively moderate trajectory, and 15% had a high rate. And then when we look at the average number of teeth lost due to tooth decay by the age of 26 by childhood socioeconomic status, You've got a difference there looking in that high trajectory. The high SES study members who had a high rate of tooth decay lost relatively few, whereas the lower SES study members of lower socioeconomic status lost fewer. Now, the proportional difference there is about sort of 1 to 4, 1 to 5, but the absolute difference is sort of almost less than a tooth. When we fast forward that to the age of 32, you'll see that the axis down here has changed. Whereas before it only went up to 1.5, now it goes up to 4. So you can see here that the difference in that high trajectory is 1 versus 3 teeth. And through to the age of 38, it's 1.5 relative to 5.5 teeth. And through to the age of 45 more recently, so 2 versus nearly 10. And so you'll see that gradient across each of these groups here in the way that tooth decay is managed. I'll come back to this idea later because we will further refine that. But in that part of my PhD, I am a dentist, and I really enjoyed the research, I really enjoyed the writing, looking at the numbers, the statistics, but I felt to a certain extent I was looking at teeth and numbers, and I felt that I might be criticised for not being a real dentist. And so I started working part-time in private practice, but more importantly for, I think, developmentally for me, was that I decided I want to see dentistry more broadly, and I visited the Pacific. I visited the Pacific for the first time, and I learned to say a big Vinaka Vakalevu to the people of Fiji. Really made a difference to me. This is with some dental therapists from the Fijian Ministry of Health who were visiting a school. This was one of the first things they did over there, visiting a school in Fiji. And this was later on the same trip. You can see there operating under a light bulb with relatively poor quality headlamp in an open air dental clinic. And it was a beautiful country. I returned a number of times, 4 times to Fiji and 2 times to Papua New Guinea, and I've got every intention of returning. It's a little bit difficult to do it at the moment while I've got children, but that was what I spent my holidays doing. Now, one particular trip, I was, I think it was the 3rd time I'd been. I was visited by a man who was about my age. He was early 30s. I was late 20s at the time, and he was with his 2 sisters. And this gentleman was non-verbal. He'd had an injury. As a teenager, he had been washing in the river, heard a noise above him, looked up, and was hit in the face by a coconut. And it really destroyed him. And so this particular gentleman, he had come to see me and needed to have his remaining teeth removed. It was extremely unhealthy. It was little shards of glass in sort of bleeding jelly, if you will. It was very, very unpleasant and difficult to deal with for him. I spent quite a bit of time with this gentleman. Once I'd finished helping him, he got up and left. I thought I'd never see him again. Now, on the last day of visiting that particular village, I was on a boat, and I had contracted a tummy bug, quite a bad tummy bug, and I decided that I was not going to go to the feast that evening until I heard that there was someone on the beach waiting for me. And so I thought, well, I'd better go. I've eaten something that I shouldn't have eaten, but I got on the boat. It was pitch black. There was only one light bulb in the village of about 300 people. and that's where everybody was. So I had my headlight on, and I headed onto the island, and there was a man waiting in the water up to his armpits, who grabbed the front of the boat when I came near, dragged the boat into the shore, and it was this man who I'd just 2 days before removed his teeth. And he gave me a hug and turned around and walked into the bush. It had such an effect on me that it made me realize, I guess, and I often think about that interaction, what it meant for that person to have his painful teeth fixed. And I wonder how he is, and I wonder what's happening. I wonder what his life is, and living on an island essentially with only one generator to supply that particular island. Now, I returned many times, a number of times. These are some images from Papua New Guinea, and this is, as a researcher, I couldn't sort of help but collect some data on the people that I helped, and this was from one particular trip where I worked together with Craig Waterhouse, and I collected data on the average number of teeth that were decayed for each age group for the people, 200 people, and comparing with. And now this is not a representative sample, of course, of people from Papua New Guinea. These are the people from the villages that I saw, and this was how much tooth decay they had, and this was how many missing teeth they had at baseline before we turned up to help them. So the of the children aged 11 to 20 that we saw, or the adolescents that we saw, the average number of decayed teeth each was 8. Compared that with a sort of approximate figure from the New Zealand Health Survey, where we'd be very concerned if we were seeing, 1, if you will. And most of that decay has been managed nicely with fillings, whereas in Papua New Guinea, we're not seeing any of that. So, on to more brighter things, though. Establishing my career. This is an image of when I graduated my PhD in 2010, together with Jennifer Doss and Lindy Foster-Page. We were all supervised together by the brilliant Murray Thompson. And it was about this time as well that I was lucky enough to be awarded that NZDA Young Dentist Award. This is a waka prow that they had carved as the supposed to be something, the forefront of the dental profession. So some other research that I've done, and the research I was doing around about this time. This is a paper from 2011. Dental plaque and oral health in the first 32 years of life. We're quite interested in the modifiable risk factors for tooth decay, and I'm very excited about what's happening now with moves to make toothbrushes and toothpaste more accessible to New Zealand children, because often those habits are set quite early in life. So we looked at lifetime trajectories of plaque. So we looked at a number of different applications of group-based trajectory modelling, including modelling dental plaque, dental visiting, and dental anxiety as well. And so we found some quite striking differences in periodontal disease by long-term plaque levels. So for study members with high levels of plaque who were smokers, the risk was greatly enhanced. For those who had high plaque levels who were non-smokers, it was only moderately enhanced. This is because of the way smoking interacts with the hygiene environment to exacerbate the issues. to depress the host response. And so we found the same sort of thing with dental caries and tooth loss. The same sort of gradients keep reappearing. It was also about this time that I met a lovely young lady, Isabella, and this is her on one of our trips to, this was at the World Congress of Epidemiology in Alaska, where she joined me. And so I've put some images here of something I learned at dental school. I applied some techniques I learned as a BDS2 student in the lab, using some wax, and then investing that to pour it in hard acrylic, to cut it into a shape, to start to build some wax on that, to get a 15-cent cubic zirconia, together with and spruing that and investing that to cast it in $15 of palladium alloy. So this is it here. That was the end result. And so that's some of the art of dentistry, if you will. Thank you. I made our wedding rings as well. I unfortunately threw mine into the rubbish. It came off in a glove. I shouldn't have had it on under my glove, and that is somewhere in the skip at dental school about 7 or 8 years ago. Now, it was just as well that I had Isabella's support, because this was around about the time I got into the fluoridation business as well. This was a challenging time. I had a lot of media engagements and a lot of advice given to professional agencies. And we'd published a paper in the American Journal of Public Health about one aspect of community water fluoridation that had come under challenge, where people had claimed that it was associated with detrimental effects on intelligence. That would be a whole nother talk to get deep into that, but suffice to say, there's another new study just from Australia that concurs with our findings. So this was a relatively influential paper. Now, I went on from this to this sort of spawned some other lines of research as well, with respect to exposure to lead in the Dunedin study, and that's been a fruitful extra pathway. It's one advantage of working in a multidisciplinary study like this. I also got interested in other potential exposures, quite interested in mercury exposure, and quite interested in looking at that. I think there's possibilities for looking at that in a study like the Dunedin study in the future as well. So new ideas are always coming. Now, I sort of segue from that because this was a beliefs thing, and I'd previously published before the fluoridation thing really got kicked off. I looked at oral health beliefs in adolescence and in young adulthood. And a couple of the beliefs that we looked at was associated with whether using fluoride toothpaste helps prevent tooth decay, whether drinking fluoridated water helps prevent tooth decay. Certainly a lot of people in the Dunedin study often changed their minds, or they felt that some of these things, like using dental floss, for example, was not important. And we found that the people that thought that these things weren't important were less likely to engage in those behaviours, but also that there were differences in health associated with those beliefs. So this was an earlier paper, which we then followed up with another paper where we used structural equation modelling to look at this through life, looking at those the intergenerational aspect, looking at the study members' parents' beliefs about looking after the teeth, their association with the study members' beliefs themselves, the study members' socioeconomic status during childhood and its association with adult socioeconomic status, There's association of these things with toothbrushing, with use of dental services, and then the association of all of these things with tooth decay, tooth loss, and ultimately oral health-related quality of life. That's where it all really matters, is because of its oral health is important because it impacts upon people's enjoyment of life. Now, my current, this is a couple of images here. I am now a little bit involved in journal editing. I've been a fairly active reviewer for a lot of journals for a considerable amount of time. I've reviewed over 300 manuscripts for different journals, and that has spawned into opportunities to be involved in editorships. There's an image of Casper, my 2-year-old, who made it onto the cover of the New Zealand Dental Journal, and some other things. I'm currently working on a artwork, if it goes according to plan. I have a pinhole camera on top of the dental school, which I consider to be the site of the original Dunedin study, and I'm hopeful that part 2 of the longitudinal issue of the Royal Society Journal, that if my image turns out acceptably, I will plan to include that on the cover. So a pinhole of 6 months of the sun over Dunedin. A longitudinal image with lovely paths, I'm hoping to see. Now, I've talked about myself a lot here, and that's a fault. The future is really, I need to start thinking about what Murray, Richie, Jules, others have done for me, and what the future should be for other people. And so postgraduate students, undergraduate students involved in research, giving opportunities for them. These are some of my current and past students. And so I'll just give a few examples here. Publishing with some undergraduate students. This is some work that we did looking at one of my lines of interest is survival of dental fillings, and so this here is outcomes for teeth after having the nerves taken out of them at our dental school, and what the survival curves look like. I followed up, there was a 1994 study on New Zealand dentists' cross-infection control practices, and so we conducted an update for the first time published in 2019, looking at what those practices are now, the proportion of dentists who now always wear gloves, or at least at the time that we conducted that survey. It would be very interesting to look at that again post-COVID. There were certainly still some gaps there at that time. This was self-report, of course. Now, one of my PhD students, Begonia, is looking at data from the Dunedin multidisciplinary health study, and she's published a couple of papers from her PhD looking at childhood oral health as a canary in the coal mine for poor adult general health, using data from the Dunedin study and the Christchurch development study as well. Also moving to a new version of group-based trajectory modelling, where we can split out, effectively have 3 dependent variables at once, and model not just total caries experience, but the really much more interesting aspect of differential access to dental care. And so you'll see here that there are different groups here who have either a low rate of tooth decay with relatively few fillings, a moderate rate of tooth decay with either quite a few fillings or a little bit more tooth loss and untreated tooth decay, or here we've got another group, the high rates of tooth decay, one of which has a lot of fillings, one of which has a lot of tooth loss, and one of which has a lot of untreated tooth decay. Some of my other postgraduate students, Emma Morelli, she looked at whether having children is associated with women's oral health. This is something that's a common claim, that you have to give a tooth per child, if you will. And one of the things that we found was that study members who had children early, relatively early, who tended to, there tended to be social things associated with that, but they were at greatest risk. So what this says to us is that young mothers especially need protection and support in making that, in their own oral health and in helping their children to adopt healthy behaviours. One of my master's students in the Master of Community Dentistry, looking at inequalities in rates of access to rates of GA in the Auckland region. This is the rate per 1,000 children for Pacific and Māori, at 10 children per 1,000 in the 5 to 9 age bracket, relative to European children at 4 per 1,000. Ludwig Jansen van Vuren and his work. This is a, Ludwig is a dental technician, and I find myself collaborating with him and supervising him on his PhD, initially because of the use of the scanner that we had purchased for use in the Dunedin multidisciplinary study. And research begets research, and we started using that scanner in this work. And in this piece of work, he's looking at stress on teeth by the contact area size, the surface area of the teeth that contact with each other, and also looking at how much the teeth compress when you bite down on them. Why don't teeth break even more than they do? They're hard and brittle, and if they didn't compress into the periodontal ligament space, if they didn't bounce a little bit, then maybe we'd fracture more teeth than we do. I'd just like to point out that I achieved 1,223 newtons. And Angela Ben, one of my PhD students working with the Dunedin multidisciplinary study as well. She's looked at some very challenging data with respect to the oral microbiome that was collected at the age 32 assessments. Very challenging data to analyse. We've just had some papers, accepted, one paper published from that and another just accepted on caries increment according to differences in the microbiome. There's some very interesting findings there with respect to specific bacteria and the risks associated with those. Simon Oliver, one of my completed Decal and Dent students, another study with the Dunedin, a couple of papers with the Dunedin study looking at occlusal features and temporomandibular joint clicking. Orthodontists like to correct malocclusions, and one of the claims that's sometimes made from correcting malocclusions is that correction of malocclusions may result in less risk of jaw joint clicking. We've found that that's not necessarily so, and in fact some features that orthodontists might want to correct are actually possibly protective. We've also looked at stability of the incisor relationship and how teeth move, how the front teeth shift around in their relations over time. Chuan-Lin Hong, a research fellow who's worked with me quite extensively on the age 38 assessments and beyond. One of her numerous projects looking at long-term survival of teeth affected by developmental defects of enamel. We've got data from age 9 of when the teeth had patches on them, if you will, developmental patches on the teeth. These patches might be due to having had an abscess or injury, or they might be due to something like, and that is what you'll observe with demarcated opacities. They're more likely to end up with fillings. On the other hand, teeth with diffuse opacities, so the front teeth with diffuse opacities, or hyperplasia, or combinations of defects, more likely to be restored, but the back teeth less likely to be restored. That's in cases where there could be fluorosis. Deanna Beckett's with her PhD thesis looking at vitamin D exposure. It's another longitudinal study, not the Dunedin study, very interesting study looking at vitamin D levels during pregnancy. Zaina Al-Nassim. Zaina is a former Syrian refugee and dentist who I'm lucky enough to have supervised her through her Declan dent, and she has published she's published a couple of papers from this work where she did a 6-month follow-up following an oral health promotion intervention among former Syrian refugees, and we achieved some lovely differences. We did a intervention and then followed up. They designed their own oral health education resources, and then we sent them back to them over a period of 6 months. So they designed them, and then we sent them back to remind them of what they had designed, and lo and behold, when they, after 6 months, they had lower plaque scores, less bleeding on probing, and some of their pockets, their gum pockets, had zipped up. I'm really interested in health promotion. This is some work that I'm currently doing with some lovely colleagues. I said I'd come back to Maunga Taranaki at the end. Myself, Kura and Sam, Kura Lacey, Sam Carrington, we have connections in Taranaki. We've been working on a puka puka, a book about oral health. Funded by the Medical Assurance Society Foundation. Doesn't matter that Kia don't live on Taranaki, that's not important. What's important is that we've made a lovely story. There's a Protodontopteryx ruthi. It's a recently discovered New Zealand toothed or proto-toothed bird that we're incorporating into the story about a Kia that's grown a tooth. Or has it grown a tooth? Now I'm at the end of my talk. What's it all about? Preventive services and enhanced access to dental care. That's what's really needed now. I thought I'd finish with a line I learned in Papua New Guinea, and I'll pronounce it incorrectly. Look out, and teeth belong you me. Look out for our teeth. Brush 'em teeth long again today, by halmiu long stop 'em teeth bugger up. Brush your teeth every day and it'll help you from stopping them from getting damaged. So, I sort of finish with some acknowledgments. So, acknowledgments to my parents. My mother was long-suffering, homeschooling me, and supported me through making sure that I did my homeschool work. And my dad is the most patient person that I could have ever met. I've got a lovely family with a lovely wife, Isabella, and 4 children who are all a lot of fun. So thank you, Lawrence and Harold, for sitting through and being very good. Thank you to Murray Thompson. I wouldn't have had a career in academia if it hadn't have been for Murray Thompson's support. It's completely all down to him, together with the support of other people such as Professor Richie Polton. Here's down the bottom is an image of myself with Lindy Foster Page, Avshalom Caspi and Temi Moffat, where we accidentally ran into each other in London. So they're also very important people who've given me a lot of support throughout my career. Thank you to friends at the dental school, those who are named and those who are not listed. There's many people who've given me a lot of support, whether it be in clinical advice on difficult cases or with respect to research. Thank you to the funders. I've taken a lot of support from the New Zealand Dental Association Research Foundation, and also have received funding from other sources as well, including the Health Research Council. I guess foundationally, thank you to the University of Otago for being the institution that has given me a career. So, kia ora, thank you. Sorry.
Ngā mihi maha. Thank you very much, Jonathan, for a very entertaining and edifying talk. Very difficult to summarise 100 publications in just an hour, but you've done a wonderful job, not only in showing us what you've done, but the diversity of your interests, including the lovely cartoons at the end. Jonathan started at dental school about the same time that I started as a teacher, and a little bit unusual because I can actually remember him as an undergraduate, though I didn't supervise any of his research projects at that point. Distinctive because of his rather understated way of asking questions in the microbiology labs, but I actually realized he was trying to distract me from looking too carefully at his lab book. Anyway, I think another very notable part of JB's career is the part of our job description which says something about conscience of society. And JB has not retreated from this at all. He's taken on various people, and that, as Paul outlined, he has the manner to do that, but it takes more than that. It takes some metatoha, I think is the word, to do that. So we very much appreciate that. What was also perhaps a little understated was that he's done all this while raising 4 young children, and that is another aspect that takes up your evenings. I was going somewhere with that, but I can't quite remember what it was. Yes, because if you've ever been into Jonathan's office, where sometimes he has to play babysitter, you can come up to date with the latest in Lego technology, which has always kept me entertained. Anyway, before we let you go, JB, we have a wee token here of appreciation. There we are.
Thank you.
And koia ke a koe.
Thank you.
Right, kia ora koutou. I'm the last. I'm Trish Priest. I'm the Acting Pro-Vice-Chancellor of Health Sciences at the moment. And I'm a public health epidemiologist, so I've had a little bit to do with Jonathan, bumping into him at meetings and things over the years, although we don't work together enough, I think, dental and public health epidemiologists, but it's always been interesting to talk to him, and I once cadged a ride home from the airport in his amazing vehicle, which was really a highlight of my airport travelling experiences. So it's really great to hear more about what you've done in your professional and personal life, and that was a really excellent and interesting IPL. Thank you so much. So I'm going to, in a moment, ask you to thank Jonathan one more time, and then to come and have refreshments at the staff club to continue the celebration. Thanks.